Well, thank you all so much for being here. I wanted to spend a few minutes just giving a broad overview of our program, and then we're honored to have our wonderful collaborators here who are going to speak about the different work that we're doing. So, at MSK, our group is called Global Cancer Research and Training Program, or GCRT, and we work to collaborate with global partners really focused on improving outcomes for cancer patients in low and middle income countries. So that's our central mission, part of everything that we do. And we do this through really multidisciplinary collaborative research and training programs. And so we're excited to share some of those with you today. Part of our vision and part of this reaching this mission is really to create a sustainable platform so that we can consolidate regional cancer data, make sure we can disseminate these outcomes to other communities who might benefit from this. Always a focus on cost efficient early diagnosis methods of therapies and thinking about ways to provide a path for professional development with education and training. And so at the center, all of this are patients, cancer patients in low and middle income countries. And research is really at the heart of advancing cancer care. So much of our work is through our wonderful partnership with ARGO, the African Research Group for Oncology, which was initially founded by MSK and OAU through Dr. Kingham and Professor Alatiche almost 15 years ago. And over time, we initially focused on colorectal cancer, but have grown tremendously to focus on many different types of cancers. We have about 100 projects in our research portfolio at this time, many in colorectal and breast cancer, but other areas as well. And our Global Cancer Research and Training Program is not just in Nigeria, but in other areas around the globe. And so today we'll give you a representation of some of our work. We have wonderful colleagues who will each speak for about 4 minutes or so about each of their projects, and then that will hopefully give us some time at the end for discussion. So we'll start with Dr. Margaret Dew from epidemiology.
Hi there. Thank you. Thanks, Vicki. The project I'll be discussing today is our epidemiologic study to examine risk factors in the biology for colorectal cancer in Nigeria. We were really fortunate, Isaac, Peter, and myself, to get this funded by the National Cancer Institute in 2020. And this study was really motivated by our goal to understand epidemiological risk factors, lifestyle factors that might be at play with colorectal cancer in the region, as well as the underlying tumor genomics for colorectal cancer. And this is because we knew from early data within ARGO, as well as other hospitals, that colorectal cancer in Nigeria looked different than colorectal cancer in other populations, both in terms of clinical pathologic features as well as genomics. But we knew next to nothing about risk factors in the region. And if we're going to design education and prevention and interventions, as well as targeted screening strategies to reduce the rising burden of colorectal cancer in the region, we needed this information. We need to know who's actually at high risk. And so that's why we launched this multi-center case control study. This was the first multi-center case control study in the region. And it included 6 of the hospitals in Nigeria, spanning 3 of 6 geopolitical zones. And in total, as of now, we have hit our target accrual, and we have 797 colorectal cancer patients, as well as 1,700 matched cancer-free controls recruited from the same hospitals as the colorectal cancer patients. And we're really building out a resource, as Vicki said, to not only support this study, but work in the future. And this includes an epidemiologic questionnaire, banking of bloods and tumors to support genomic work, including germline sequencing, as well as tumor sequencing, and clinical data annotation. And so our hope is obviously that we're building a valuable resource for the research community as well to study colorectal cancer in this population moving forward. And today, I'm really going to focus on the epidemiologic risk factors, just because we are still generating genomic data, and hopefully that will be coming soon. Flip. And I know this is a lot. I tried to just pack everything in here because I know I didn't have very much space. But the take-home message of this is we first tried to replicate the risk factors that have been identified in high-income populations. And we basically thought, hey, why reinvent the wheel? If we could use these risk factors for informing education and interventions and risk stratification, we should do it now. And so we first tried to replicate the risk factors that had been identified in high income populations in our Nigerian population. And we see that certain risk factors do. This includes family history, height, a composite somatotype, which reflects body size and type over a lifetime, and processed meat intake, which was associated with increased risk of colorectal cancer. And we observed quartiles of physical activity as associated with decreased colorectal cancer risk in our population. We also observed an unexpected body mass index association where increasing body mass was inversely associated. But we think this is a reflection of the fact that we have many late stage participants who come in with advanced cancer and they've already lost weight prior to their diagnosis. And so this was weight taken at diagnosis. So we don't think that body mass index is necessarily the best measure in our population as a risk factor here. Next slide, please, Vicki. And in addition to the known risk factors or the published risk factors, we also have been looking at factors in addition to these that might be a little bit more novel or important specifically in our population. And one of these includes dietary patterns. We examined 6 diet patterns. This included 3 data-driven patterns using principal component analysis, so defined within our study, which includes a westernized kind of meat-heavy diet, an African traditional diet, very carb-heavy, as well as a diversified African diet, which is very, includes pretty much a little bit of everything, as well as 3 published healthy eating indices, including the Alternative Healthy Eating Index, the DASH diet, and the Mediterranean diet. These are well-published dietary indices associated with reduced risk of chronic disease in high-income populations. For the data-driven diet, we saw an increased association with the westernized pattern, where high compliance to this dietary pattern was associated with 70% increased odds of colorectal cancer. And interestingly, the Alternative Healthy Eating Index, which was designed and validated within high-income populations, also does have a suggestive inverse association within our population. And so this is really interesting to us when it popped up because it suggested to us that, well, one, a lot of folks have been hypothesizing that the westernization of the diet is one factor that might be driving the increase in colorectal cancer. And ours is one of the first studies to be showing that there might be some support for this. And also that a healthy eating index designed in a high income population applies to Nigerians as well. We've also done a very small pilot study looking at silicone wristbands to assess environmental exposures. And this was done at Obafemi Awolowo University in about 50 individuals. We approached 54 individuals and 51 consented and returned their bracelets after 7 days. These are just silicone wristbands folks wear on their bracelets for a week and it sucks up the environmental exposures. The bracelets are assayed at Duke for environmental chemical exposures. We looked at 137 chemical compounds across 11 compound classes. And this included lots of different types of chemicals. And what was really interesting for this is we saw 27 chemicals present in more than 80% of the population, 7 of which were actually heavily banned or regulated by European or US regulatory agencies, really reinforcing why it's so important for us to be looking at these questions within Nigerians, where widespread exposure to monitoring is not really done at the moment. And we're very excited to be replicating these findings in the future in a larger population, both for this and the diet patterns. And yeah, so a lot more follow-up to come, but here's some of our early data from the work we've done.
Thank you so much, Margaret. You got a lot into those few slides.
Sorry, I think I went over 4.
No, that's okay. It's okay. So now we'll move on to early diagnosis. First, we'll have Professor Isaac Alatishe from OAU and the co-founder of ARGO.
Thank you, Vicky, and nice to be here. One of the foundation of our study started when we started the database, trying to gather the clinical database prospectively. And we were happy that we were able to do this after about 2 years. And as we were hoping to celebrate our achievement, we decided to analyze the data that we collected for colorectal cancer from 6 of the teaching hospitals, and all the data was prospectively gathered. Unfortunately, one thing that we found out was that by the end of 1 year, a half of our patients that we have in the database, they were dead. So that changed our focus from having the prospective data to not just having the data, but making an impact from the data. One thing we realized early on is that the majority of our patients present very late, and there's very limited evidence as regard what really work. How can we diagnose this patient very early? Just populate this slide. Thank you. And our resources to conduct the screening are also very minimal. Even if you really want to find a diagnosis, you know what works. The resources to do this evaluation, to screen the population are very, very limited because of weak system. And so it is very clear to us that we have to be innovative to be able to identify the group at risk and screen that group for maximum benefit so that we'll be able to justify the funding that is being spent in this kind of a project, because there's so many competing demand in the system. Next slide. So we embark on different strategy to evaluate detect colorectal cancer early. And one of the first project that we did was to use the already projected guideline for low middle income country. Almost all society projected that stool-based test should be the first screening modalities for low middle income country. Why that was suggested, nobody knows, because there's no evidence. There's a little feeling within our mind that this may not work because of a number of benign conditions that we have. Diarrhea condition associated with stooling, a passage of blood in stool in this part of the world, but we don't have evidence. And that's why we decide to deploy the FIT, qualitative FIT, in about 2,300 patients. The finding was so revealing because the false positivity, as we suppose it will be, was very high, about 21%. Usually that was quite low, and the positive predictive value for using FIT in our population was very, very low. False positivity was high, and positive predictive value was very low, which was 1.1. Averagely, most screening modalities suggest that it should be in the range of 10%, but in our environment, it was very low, meaning that if you have to deploy this screening modality for colorectal cancer, you have to be doing so many useless colonoscopy, which we don't even have resources to do. And that's why we start thinking, what could be the best way? From our colonoscopy data, we know that majority of those patients that present with colorectal cancer often present with bleeding parectum. And most of the bleeding parectum are neglected for a long time. And that was why we evaluated our initial study looking at clinical symptoms and from the community. And that shows that we may be able to pick many colorectal cancer before they can become advanced, before becoming advanced or metastatic disease, which is the condition where we pick them. So recently, we just completed a pilot study looking at 2 local governments from Osun State. From the community, we did a lot of educational program in the social media, in the community, raised a lot of awareness concerning colorectal cancer. And we encourage as many of them that have symptoms to come for free screening. From that program, we were able to identify 415 patients from the peripheral clinic. And out of this, 341, which was about 83%, was navigated to the clinic. Not all of them showed up, but significant number of them, about 96%, came to the hospital. And eventually, only 168 by the guideline that we set up were actually eligible for colonoscopy, and we conducted colonoscopy in 73% of them. Next slide. So, expectedly, of course, quite a number of them have benign condition, but if you look at it, the polyp that were detected was around 27%. Averagely, polyp detection rate in our environment is usually in the range of 15%. But in this population that have symptoms, the polyp detection rate was 27%, though advanced adenoma detection rate was 11%, which was even slightly higher. Most of the data from our environment usually quote about 5%. And we saw colorectal cancer, 4 colorectal cancer cases. 2 of them actually have cancer cancer in situ. They have advanced adenoma with non-invading, infiltrating adenocarcinoma. And one of them has stage 2 colorectal cancer, and one has stage 3 colorectal cancer. In essence, out of the 4 colorectal cancer, we were able to take 3 of them that were in a stage where you can cure them. They don't need chemotherapy, they don't need radiotherapy. And we were able to offer them this treatment, and they were cured, and they've been alive up to now. For your information, you note from our database, only 1 out of 2 of those patients that are alive at the end of 2 years. When we finish this, all these patients that we picked up at advanced, at early stage, they don't need a ton number of money to be able to treat them, and we're able to cure them. So currently our plan is to scale this up and do an implementation using a randomized stage-wise trial in the Osun State, which is one of the 36 states in Nigeria, and hopefully scale this up. The data from this we know will change the practice in most low middle income countries, giving us evidence on how to identify colorectal cancer early and to treat them in a cheaper, treat them without breaking the budget. Next slide. We've also tried to deploy technology in early diagnosis of colorectal cancer because we know that there are some structural barrier with the use of stool. We decide to explore the urine. Could there be anything? And the result is quite eventful. We did a mass spectrophotometry on over 500 colorectal cancer and control, looking for what metabolite that light out in the colorectal cancer patient. And we found 3, which were diacetylspermine, hydroxyl epurate, and glutamate. And these were the best metabolite that we found. And in the pilot study that we did, the sensitivity of this, especially combined with symptoms, was close to 100%, and the specificity, which was preset. Actually, what we got was around 80%. The specificity that we set for this was 50%, because our desire is to reduce the number of useless colonoscopy that will be done trying to screen for colorectal cancer. Our current plan is to do this not only in Nigeria, in 4 countries in Africa, and see how sensitive are these metabolites in detecting colorectal cancer. Like Margaret said, there's a lot that we hope to share with you in the nearest future. We are also exploring blood. How can we identify colorectal cancer early using blood? Working with Johns Hopkins University, we are trying to develop a gene panel, 5 gene panel that can be used, that can be adapted to GeneXpert Strat4 device. And currently we are testing the panel, and the current result that we have is quite encouraging. And we hope in the next few months to few years, we'll be able to tell you about what are the genes that we found to be useful, and how can this be deployed in a wider community. I think that's all from my end. I'll move it back to Vicky. Thank you.
Thank you so much, Isaac. Really exciting to see all that progress. So now we'll shift gears a little bit, talking about early diagnosis within breast cancer. So I'll turn this over to Dr. Lei Amashori, a radiologist at OAU. Thank you, Lei.
Thank you. I'm happy to be here. So I'll be talking about our project, which falls under the early diagnosis studies. It's Tibet-based mobile health ultrasound-guided biopsy training program for radiologists in Nigeria. It was funded under the R21 category of NIH projects. Next slide, please. So, by way of background, delay in diagnosis is a major contributor to the poor breast cancer survival outcomes in low to medium income countries. And WHO has recommended that the diagnostic interval, that's the time between when a patient presents and when you have a tissue diagnosis, shouldn't exceed 60 days for LMICs. Now, a significant contributor to this delay is the fragmented back and forth between providers. Evidences and research from high-income countries have shown that ultrasound-guided biopsy is an effective method with high accuracy for diagnosing breast cancer. However, prior to our training program, most Nigerian radiologists did not have the skill to perform this procedure. It hasn't really been part of the training curriculum in the residency training in Nigeria. However, we know that this building capacity for ultrasound-guided biopsy has the potential to streamline the diagnostic pathway, reduce delays, the back and forth between providers, and ultimately improve survival outcomes for women with breast cancer in Nigeria. So we wanted to build capacity for ultrasound-guided biopsy. So our first aim was to develop a competency-based training curriculum to train radiologists using the train-the-trainer model. And then we'll validate the assessment metrics. And then after we developed the curriculum, we wanted to train AGO radiologists. Those are Nigerian radiologists working in AGO institutions using this curriculum. Next slide, please. So to develop the curriculum, we actually consulted the American College of Radiology Practice Parameters. We had a review of the BioRads Imaging Reporting and Data System Atlas, and then we looked at the breast imaging fellowship curriculum at MSK. And we had to tailor this into the Nigerian setting. So we had to do something that was context specific for the Nigerian hospital. And then we defined competency assessments at 4 levels. We looked at assessments at the simulation biopsy level, patient biopsy level, then looked at competency assessments with biopsy accuracies and then the complications. And we used the O-score tool, which is the Ottawa Surgical Competency Operating Room Evaluation, which has been validated as a tool for assessing surgical skills in surgeons. Next slide, please. So we came up with a curriculum that was in 6 steps. The first 2 were more of abstract and reading and learning, while the next 2 stages were more of practical. So the first stage has the step 1 and 2. The first is the instructor-led, where Dr. Sutton, myself, and some other radiologists from MSK actually took radiologists through some didactic lectures, exposing them to ultrasound-guided procedures. And then every radiologist that was enrolled then had to go through an e-learning process. And the e-learning was actually hosted on the Talent platform. And you can see on my slide, you can see just a screenshot of what the e-learning platform looks like. Yes, thank you, Vicky. And before that screenshot, you can see Dr. Sutton there during the instructor-led phase, where she was trying to demonstrate a phantom-based biopsy training. And then after that, the trainee had to actually be certified competent before they move to the next step. So it was the sequential thing, moving from instructor-led to e-learning, and then they go into the simulation biopsies phase, which consists of both the supervised and unsupervised. At the supervised phase, they're actually doing it with a supervisor watching and be able to certify competence. So it's arm to arm, the training and the trainer. While at the unsupervised phase, once they have attained competency at the supervised phase, then they go over to the unsupervised, where they are supposed to perform this phantom-based training without the supervisor being there. But of course, they'll do some videos that they will send for certification. Then once each trainee gets certified at the unsupervised phantom-based training, then they go to the supervised patient biopsies, and at supervised patient biopsies, they are using it's patient-based, and then they are arm to arm with a trainer. And then once they are competent, then they move from that phase into the unsupervised biopsy, patient biopsy phase. Now, the aim of the first 5 steps is actually to certify that the trainee is competent to get to do biopsies unsupervised in their institution, and subsequently enroll them for a prospective clinical trial that we later conducted. So we published the protocol of our training curriculum in cancer control. It's out there. So we actually put up the curriculum out there. And that's, I put a screenshot of the manuscripts of the paper, of the published work there. Now, during the study period, it was a 2-year study period, 13 agro-radiologists were actually enrolled, and all of them went through the 4-part competency assessments. These 13 radiologists came from 8 teaching hospitals across 3 geopolitical zones in Nigeria. 12 of them completed the competency-based training and subsequently were enrolled into the prospective clinical trial. So along the line, we did like a side study to look at the population level access to breast cancer early diagnosis in Nigeria, trying to look at the impact of the R21 training program. And we saw that there was actually a 30% increase in population level access to ultrasound-guided biopsy, particularly in the South, compared to the northern part of the country. And that's the paper also there, which was published in JCO Global Oncology. Now, all the 12 radiologists that were enrolled in the clinical trial actually now had to recruit a minimum of 25 patients, 18 years above, with a solid breast mass that had some suspicion for breast cancer. And preliminary results show that the diagnostic interval actually has a median of about 41 days, which is within the 60 days that WHO actually recommended. The full results are waiting publication. I didn't want to come and bore us here. But right now, we are at the phase where we are trying to validate the curriculum, the training curriculum. So all out of the trainees, 5 of these trainees are now trainers and training new sets of trainees in their institutions. And the institutions involved in the validation phase are OAU, LASUF, LUTH, FMC, and then UNCH Enugu. So we are trying to validate the curriculum and trying to pull out the full results of the publications out there. In the 2-year study, during the clinical trial phase, I think total of about 685 women were biopsied, and we had cancers were diagnosed in about 480 something of them. So, but we are trying to put out the full results there, and then our next phase is actually to apply for an R1 and do a 5-year project involving all geopolitical zones in the country with more radiologists being trained. Thank you very much.
Thank you so much, Leigh. Exciting to see you build on this work. Now we'll go to Dr. Diana Ng, who's one of our pathologists at MSK.
Hi, everyone. So Dr. Omasor gave a really great perspective from the radiology kind of view. And so now I'm going to give the pathologist perspective. And so over the last few years, I've been working very closely with collaborators at the UCSF Global Cancer Program, as well as the MUHAS ORCI UCSF Cancer Collaboration. And we've been working to look at a multi-component program to improve hormone receptor testing for breast cancer in Tanzania. And based on our preliminary data, basically at the National Referral Hospital, Muhimbili National Hospital in Dar es Salaam, even even women who make it to that point and get a pathologically confirmed breast cancer, only half of them end up getting ER, PR, HER2 testing. So we found this to be a significant gap that we needed to look into. So Vicky, if you could just click maybe 3 more times. Okay, right. So I think there was some mistranslation with the technology, but so part of that was actually doing a qualitative situational analysis. And what we did is we asked over 60 kind of key stakeholders in cancer care, including clinicians as well as administrators, and as well as patient survivors, on what needs to happen to improve hormone receptor testing, and what were the barriers and facilitators to introducing a new intervention to improve breast cancer biomarker testing across Tanzania as a whole. And so, there was a lot of data that we collected, and essentially we conducted a thematic analysis of these semi-structured interviews as well as focus groups. And we use an implementation science framework to analyze these data. And so we map these themes to CFIR domains and constructs. CFIR stands for the Consolidated Framework for Implementation Research. And a few things I just wanted to highlight that I personally thought was interesting was that many people talked about the need for a local validation study and to really highlight the locally published data to key stakeholders. Other things that I thought were interesting is a lot of people mentioned, changing how patients pay for services. So right now they pay for things piecemeal. And what people said would actually really benefit patients is bundling pathology services so they know what the diagnostic costs are upfront, as opposed to being surprised with every step there being another cost and another cost and another cost. Another thing stakeholders mentioned was the need to advocate for inclusion in the national treatment guidelines. And in here, that's because to even possibly be considered to be reimbursed by the national insurance, it needs to be in the national treatment guidelines. So indeed, the national treatment guidelines mentions the need to do biomarker testing, but it does not mention any potential new technology. So if we're going to introduce a new technology, it has to be in this guideline. Other things that people mentioned that we really need to consider if we're introducing an intervention is how this intervention is going to change the demands on personnel as well as their roles, how it's going to impact any pathways and workflows in the hospital. And then also some people mentioned that prior interventions failed because they weren't communicated well to healthcare personnel, and they didn't necessarily have clear goals and were not evaluated well. And then one other interesting item that we found was that there was kind of a mixed opinion on the relative priority of hormone testing. And it was because most people felt like the delays in care were not because of the hormone testing, but really happened prior to patients' presentation to zonal or national referral hospitals. And how we understood this was that hormone receptor testing is really one component. It's a cog in the wheel of the system. And so, of course, our group is part of a multidisciplinary team. So in addition to working on diagnosis, really, we also need to be looking at interventions that are improving community outreach, that are improving treatment, that are improving patient navigation as well. So, it's not something, you can't just look at one small variable and not do anything about all the other barriers. All right, next slide. Okay, one more. All right. So aside from kind of these more qualitative assessments, as well as getting a better understanding of the health system, another component of our research has really been looking into improving both existing technologies as well as looking at novel technologies. And so this is a work that I worked really closely with Cefiad on, along with Dr. Edavula and Asteria Kamambo. And here what we looked at was the Strat4 device that's manufactured by Cefiad. And essentially, there's been previous literature that has tested it using formalin-fixed paraffin-embedded tissue. And using FFPE, it's actually has shown very, very robust results, especially for ER and HER2. And what we did is that we actually used fine needle aspiration biopsy samples And we used 4 different proposed processing methods. So all the way from the most complex, which is kind of the manufactured recommended protocol for FFPE, all the way to a one-step protocol, which we call the Maui protocol. And the reason why fine needle aspiration biopsy samples are so important, especially in the sub-Saharan African context, is because many places do not have access to core biopsies very readily. I know there's a spectrum for whether people are able to access core biopsies, but FNA is still a very relevant sampling method. And so if we could use FNA, our hypothesis was that you would actually be able to have same-day diagnosis where someone does a rapid on-site evaluation, they diagnose breast cancer, you put in the cartridge, 2 hours later, you get a ER/PR HER2 result. And so we kind of stress tested this device. And so what we found is that there wasn't necessarily a single protocol that really shined and performed extremely well with all 4 biomarkers. And what we found is that the 1X protocol was really, really strong for ER, where there was an extremely high concordance with immunohistochemistry, which is the gold standard on formalin-fixed and paraffin-embedded tissue. If you click one more time, Vicki. Okay. And then for the Maui protocol, I think the Maui protocol performed extremely well with HER2. I have to say the Strat4, again, was developed for FFPE, and these results are based on basically no additional kind of adjustments. And so our hope is that in the future that, there might be some investment to further refine this cartridge for fine needle aspiration biopsies so that it would open the door for additional sample types to be used. And here you can see some of the figures really focusing on ER specifically, which can have a very high impact. So you could see that even though 1X did perform the best, all 4 protocols did perform very well on ER specifically. Next slide. So other technologies that we've also looked at is, well, actually IHC, and IHC is your bread and butter, it's your gold standard. But what we did is, again, we looked at whether we could use cell block samples, again, procured by fine needle aspiration biopsies, which would expand essentially the specimen types that can be used for breast cancer biomarker testing. At MSK here, we do IHC and predictive markers all the time on cell block. But this is basically almost never done, at least in Tanzania. And so here we showed that for looking at ER specifically, we had very, very high concordance between a accredited laboratory at UCSF and then the cell blocks over at MNH. And you could see, to be honest, I can't even tell which cell block came from which laboratory. I think they did an excellent job. And I think this was really powerful in increasing their diagnostic capacity, not just for ER, but being able to do IHC on cell blocks and being able to improve their diagnostic capacity. Another technology that we were also kind of looking into was a optical nanosensor. So this is work that I was doing with Ryan Williams, who is a biomedical engineer at City College of New York. And we were able to get a small pilot grant where he basically works on optical nanosensors that leverage single wall carbon nanotubes, which act as a scaffold. He attaches a specific antibody that can attach to different proteins. You just have to design it. The antibody that we selected was for ER alpha. And so here, this was just a methods development paper, really determining whether this was feasible or not. Because ER is a nuclear protein, we weren't even sure if this optical sensor would work. He had only worked on cell surface proteins. And what we found is that there actually was a spectral change when we tested it not only on cell lines, but also biobanked patient samples, so simulated FNAs. And so we're hoping to continue this work with additional grant funding and refine it so that it potentially could be clinically deployed one day. And so that's just a small sampling of a few of the things that we've been working on.
Thank you so much, Diana. So next we'll hand it over to Dr. Lakan Olasahinde, who leads multiple breast cancer projects within Argo.
Okay. Thank you very much. Very quickly, I will just walk us through some of the things we've been doing with respect to clinical guidelines. The foundation for this work actually came from the first review of our database. We have a database that's lasted over about a decade now, with currently has over 2,000 patients enrolled within it. Our first review of the database showed a lot of interesting findings, one of which was the fact that 5-year survival for breast cancer patients was remarkably lower than what obtains in high-income countries. What we also found in addition was the fact that when patients received guideline concordant care, their survival was somewhat similar to what obtains in high-income countries. For instance, patients who had stage 3 disease, who received surgery, appropriate chemotherapy, as well as radiation therapy, had 5-year survival close to 70%. And that was quite remarkable. And that was the foundation for these projects. So the first step we took was to expand the database so that it has a national face. For the first 7 or 8 years of the database was limited to OAU. So we expanded it to 6 additional sites covering all the geopolitical zones in the country. So after we did that, and that's been running now for about 2 years, currently we have over 2,000 patients enrolled in the database across all the sites. So next we moved on to assessing guideline adherence, evaluating how patients are actually being managed, looking at data from the database. And I'm going to present a bit of what we've found so far. We also assessed guideline adherence subjectively by conducting a national survey of healthcare practitioners involved in breast cancer management. So we evaluated practices of surgeons, of clinical oncologists, radiologists, and pathologists, not only to assess their practice, but to also understand the facilitators and barriers to a guideline concordant care. And putting all of this together, we felt we were going to be properly informed to develop interventions that can help improve guideline adherence. Next slide, please. So I'll present a bit of the reports of what we found so far from the database. This is our first evaluation, and we used the WHO GBCI pillar. There are 3 main domains. First is the early detection, which I think Leia mentioned earlier. The goal is to achieve at least 60% of patients presenting with stage 1 or 2, the early stage disease. The second goal is timely diagnostics, which is to achieve a clinical diagnosis from clinical presentation to diagnosis within 60 days. The treatment domain actually stipulates that the goal for the treatment domain is to achieve at least 80% treatment completion amongst patients that presented. We don't yet have mature data to assess the treatment. So what we've done so far is to determine what proportion of our patients receive treatment within 90 days. And we did that because that has been shown to significantly influence survival. So from our initial review, only 16% of patients across all the geopolitical zones achieved presented with early stage disease. In terms of timeliness, much better, about 50% of patients received pathological diagnosis between the time they presented to any facility and the time pathologic diagnosis was made. And then in terms of treatment initiation, nearly a third of patients in the database received initiated treatment within 3 months of first presentation. Now we looked at healthcare practices across the country, and we assessed the knowledge and the usage of guidelines, as well as also asking what factors can facilitate guideline adherence. So the majority of patients were aware of guidelines, and the overwhelming majority of them believe that guidelines contribute to better outcomes. However, only about half of them do consult them. Interestingly, for a couple of years now, Nigeria had adopted the NCCN harmonized guidelines as its own cancer treatment guideline. That's been communicated to nearly every institution. But barely a third of respondents were even aware of the existence of the resource-adapted NCCN harmonized guidelines. When asked what practitioners think can improve guideline adherence, the majority of them recommended multidisciplinary meetings as a way to promote guideline adherence. Now, the chart to my right, still back to the initial slide, the chart to my right was one of the most interesting findings in that survey. And we found that practitioners who engaged, now the red bars, they just indicate the proportion of respondents who use guidelines. Now, the more practitioners were involved in MDTs, the higher the likelihood of they utilizing guidelines. And you could see the red bars just increasing as you go towards the right, with those who don't participate in MDTs. Barely 20% of them use guidelines, compared to about 60% of those who use MDTs. So using the AORTIC framework, we sought to determine what interventions would be best in order to promote guidelines. And the two major interventions emerged, and one of them was the adoption of MDTs. Next slide. So we implemented, about 5 months ago, breast cancer MDT at OAU. And started about 5 months ago. It holds weekly, and it has consistently held since inception. The core members are surgeons, clinical oncologists, pathologists, radiologists, nurses, and oncology pharmacists. We've had 21 sessions over the 5 months period, and the average attendance has been 23. We've reviewed 65 cases so far. We've had 7 didactic lectures, because we also felt it's one of the advantages of the MDTs to serve as an educational platform. We've done 2 journal article reviews. We did an initial evaluation of the program at 3 months. It will be repeated at 6 months, at 9 months, at 12 months. And then our ultimate aim, is to reevaluate guideline concordant practice, first at OAU, which is the site where this is being implemented, to see if we fare better compared to where we were baseline. Thank you. That's the much I have on that.
Thank you so much. I'm sensitive that we're running short on time. So you have Dr. Folo Balogun, GI oncologist at MSK. You have a wonderful trial to talk about. I'll just challenge you to keep it to just a few minutes, if at all possible.
Yes, I think I could do that. Thank you. Hi, everyone. Thank you for your attention so far. So this slide, really, the key take home is that colorectal cancer that's mismatch repair deficient, or MSI high, it has been established that standard of care is to treat it with checkpoint blockade immunotherapy. So the top row, or the top row with the slide to the right, shows us that when you treat patients with stage 4 mismatch repair deficient colorectal cancer with immunotherapy, pembrolizumab versus chemotherapy, we see a significant benefit, the blue versus the red one. So that has become standard of care. And in the lower study, that was led by Dr. Luis Diaz here at MSK. Also the senior PI for the second one, which is led by Dr. Andrea Sursek. The lower row does show us that in localized rectal cancer, when you treat patients with mismatch repair deficient disease with immunotherapy, you actually cure the disease, cure them. So right now it's been over 40 patients, and it's still 100% cure rate. For perspective, this typically requires, or as a reminder, radiation, chemotherapy, and surgery to obtain this level of cure, as opposed to 6 months of immunotherapy. Next slide, please. Quick question about why OS, the difference in OS is not as prominent as what we saw in PFS. There was a crossover allowed. So patients in the chemotherapy arm, when they progressed, they were allowed to go to the immunotherapy arms. So that was why we don't see a significant, we see a doubling from 8 months to 16 months with the progression-free survival, but it's less when you look at the overall survival because they get to go to the benefit of immunotherapy, which is the right thing to do. So here in this slide, and the key take home, and Dr. Alatish already talked about the trial here. The key point here is that is the question of whether the biology in patients, Nigerian patients with colorectal cancer is different from what we see here. This is important because the beautiful data I showed you on the last slide, they were global trials, but did not include global in terms of North America, essentially high-income countries, without patients in sub-Saharan Africa for most of that, South America. So there's the question of how can the biology be different, whether that's genetic or geography related. Now, take-home point here is we see that there's a difference in patients with colorectal cancer in Nigeria versus US in terms of their having a younger age of diagnosis in Nigerian patients. And we also see a difference in metastasis pattern. So more peritoneal in Nigeria versus more liver lung here. And we can click one more, please. And we actually see differences in the molecular when you look at the genetics. The key thing not highlighted here, which I typically highlight, is the MSI high. We saw about a 28% MSI high in colorectal cancer in the Nigerian patients versus 8.5, about 10% really in the US cohort. And we also see some other molecular difference that suggests there could be a difference in biology. Why that's very important is that mismatch repair deficient response to immunotherapy, if we're having more patients have it with that histology and biology in the Nigerian cohort, then they stand a chance to benefit significantly more than, even more so than the from having access to that therapy for immunotherapy. Next slide, please. So this led to a trial which we're going to be opening to accrue pretty soon, later this year. And here we're essentially seeing patients, Nigerian patients with colorectal cancer that's mismatch repair deficient. If they're treated with checkpoint blockade immunotherapy, what do we see? This is not something that's been looked at in that population or most of sub-Saharan Africa or low and middle income countries, as a matter of fact. So we have two cohorts, a cohort that has metastatic colorectal cancer and a cohort with localized rectal cancer, similar to the trials I'd shown you earlier on, or the results I'd shown you earlier on. This will be 40 patients, 20 in each cohort that will receive immunotherapy, checkpoint blockade, tislelizumab, and we'll monitor for response to estimate response, but also feasibility of therapeutic trials, clinical trials like this in Nigeria and other low middle income countries, where we can hopefully create a pathway or lead a pathway in which immunotherapy can be used in for clinical trials in this setting. And we'll also estimate outcomes in terms of survival and response in this population, which currently doesn't exist. And that's it.
Thank you so much, Bulu.
Thank you.
So in the interest of time, we won't speak in depth, but I want to acknowledge Dr. Alisa Hinde's leadership in another study looking at de-escalating breast and axillary surgery. Hopefully we can provide an update to that at a later time. And then just quickly, two of our training programs. We have our Nigerian Cancer Research Training Program, led by Dr. Kingham and Professor Alatishe, with the goal of strengthening research capacity in Nigeria. This includes workshops, coursework, and providing mentorship for research. So we have clinical research scholars. Have about four cohorts of about 12 people each who we sponsor to enroll in the Harvard Principles and Practice of Clinical Research course. And then we also have postdoctoral fellows who spend a year at MSK doing mentored research. And then we're now in a phase of bringing them together for team science. So using what they've learned to build their own independent research projects and a focus on multidisciplinary efforts. And then lastly, I'll ask Dr. Omolade to speak about the Global Online Breast Pathology Fellowship.
All right, thank you for being here. The Global Online Fellowship in Breast Pathology, it's an innovative program that was created to bridge the gap in subspecialty pathology education. And this program have two curriculum, is in two parts, which is the synchronous and the asynchronous part. The synchronous part is a weekly one-on-one interaction between the participant and faculty for 1 year, as well as the real-life cases provided by our faculty and the fellowship. The asynchronous, it's actually based on Google document organizing modules, which the modules are in 11 modules, and we have reading material, lectures, assignments, which are marked and scored to know how the how learning is going on. And in addition, there are also 1 month observership at MSK, which is sponsored by the MSK Global Cancer Research Training Program. And this program is sustainable in fact that it's the faculty, the trainer, there's train the trainer approach, and the trainer or the trained person becomes the faculty, and at the end of the day, in some occasion. So this slide just talked about the logic model for the Global Online Fellowship. I will quickly say that the stakeholders are the learner, which are general pathologists from medium income countries from Nigeria, Tanzania, and Mozambique. And the educator is Dr. Marcia from MSK, who has a great experience of about 16 years. And as I said earlier, it's an online program. And the resources that we use is we use internet as a digital scanner, even though not all the centers have digital scanner. Some of them will use their phones and camera to snap the slides for discussion at every point. And the goal also is to provide a basic knowledge and using their material so that they can learn. And also, the people that we recruit are people that can speak English, that can learn with English proficient, so that they can have a good interactive sections. And the processes is we identify gaps of knowledge during facilitation by direct.
Oh, Bedico, I lost you. I don't know if that's my connection or yours.
No, I think we lost her.
We lost
Yeah,
her.
we lost that. So I think we should just continue.
Okay.
Oh, okay. Go ahead. Yeah.
Okay, model. Can you get me?
Yes, we can hear you.
All right. So model, then what we have accomplished so far, we have successfully completed 3 teaching cohorts online. We have nine fellows in total. We graduated about 2 in 2022 and 3 graduates in 2024. And about 3 of them have been recruited to become part of the faculty. We have myself, Dr. Oluwatosin from OHAC, and Dr. Male from Ibadan. And most of these participants are recruited from Agro site, as far as Maiduguri and in Nigeria and other places, so that they can have easy collaboration and all of that. Then the participant outcome, we've seen a great improvement in the confidence level of reporting breast cancer and making diagnosis. And why this program is very interesting is because most of the participants, they bring their own cases from their hospital, and we learn with that, and we ask questions, and we've seen a great reflection. And from this score, we are able to, we have 2 abstracts to present at the next AORTIC in Tunisia. This 2 abstracts to present, as the title, you're looking at the title below. So these are memory pictures where we, during AGO conferences, give certificate to participants and also the faculty members. We have on our very far left is me, myself, Professor Latishi, and Professor Kingham, then Tosin and Dr. Malade on the far right, and Mozambique, one of the fellows from Mozambique. And also the last on the left, far right, is the teaching section where our facilitator, Dr. Marcia, came. We learned how to gross a mastectomy specimen and how to report a mastectomy specimen. Thank you for listening.
Thank you all so very much. I know we went a little bit over the hour. This is a tremendous amount of work by a large team of people, and I'm so grateful to our speakers and to AORTIC. I want to recognize that all of this would not be possible without a lot of support from MSK, numerous foundations, and certainly the NCI as well. And if you're interested in learning more, this is our website, as well as our social media. And so with that, I'll stop sharing. I know we've run short on time for questions, but maybe we can connect offline if there are questions later. So thank you so much.
Thank you to the MSK team. And this is the beginning. I was hoping that we were going to have MSK next month. And honestly, 3 months in succession, because there's a lot to talk about. I have a lot of questions that I start writing up. So you have to come back, and we will start with the questions. For next month, we are going to be having UNC coming up for the hour for September 2nd. And the hope is that we continue to come every month to discuss what we are doing, to train our trainers, to show off, and showcase, not necessarily show off the work we are doing, and hopefully getting collaborations from that. One thing we want to announce is about our AORTIC journal. We are launching our AORTIC journal, and we'll hope that you submit your work so that you get published in the AORTIC journal that is being launched. We don't have a slide to share, at least for everyone to know this. There's a lot of questions. I'm just going to rattle through the questions and hopefully food for thought for us. And number one thing is when we're talking about colorectal cancer screening, right? I'm thinking that how many patients do we need to treat, or do we need to screen? We have to start thinking about things like that before we start thinking about the effects, the benefit, or the cost implication as far as the screening is concerned. And then another thought that came to me was I saw that for patients that were high income patients, were more likely to have colorectal cancer or positive colon screening. So I'm thinking probably if we can, maybe if an algorithm can be developed, and maybe that would tailor down and and actually justify the screening process. And then this one was for Dr. Adelaide, which was where she was talking about the trainer. So I was thinking about with the use of AI models, human resources is always a problem in low middle income countries. I'm just thinking about the use of AI to be able to reduce the number of human resources that we might have. And then the other thought of, I don't need an answer, this is just me throwing out there. So this is me saying that the next time we are coming, we have to leave a solid 15 minutes for question. As I'm answering this question, a lot of people are like, we have a private chat, everybody's asking questions. So you have questions. So my summary is you have to come back. That's all. So this is like 9 minutes after the hour. This is a very, very excellent session. I enjoyed everybody's talk. It was very clear, and we hope you come back. And Professor Latisha, you need to change your previous picture. That one you showed was when you were like an assistant professor like me. Now that you're a professor, we need an updated picture. That's another feedback we are giving to you. And
You can be sure that we are not running away from all the questions, and even the one that you asked, we have answered for them. But
I know you do, but it's 10
we,
minutes after
we
the hour. I
apologize
want to be
when
respectful of our time.
Okay.
we it shows that we've been working for years, and we just have we couldn't we just went through half less than a third of the project that we have.
No, this
But
is like
we appreciate
10%. This is the tip of the iceberg. So Bemura will work with you for you to come back, so that we'll open the whole thing with questions. And this is really very wonderful. And I really want us to come back. So this is 10 minutes after the hour. I want to be respectful of the time. Does the president have anything to add? Apart from our AORTIC journal, we are launching that and we need you to submit your work for it to get published. All right. So thank you again. We'll hope to see you again September 2nd. For the MSK team, please.
Nothing to add. I think it's just been an excellent discussion.
Excellent. Yeah. So MSK team should please join us September 2nd, right? Because I just realized once you present, everybody moves on and then we have crowds. I see whose crowd is who, but please, I will hope that we are consistent and we're able to move this forward. Thank you again for this session. Thank you. Bye-bye.